Those of us here at Colorado State University are proud to share with you this session of Endoscopy Talks. When you're looking for inspiring veterinary CE experiences, think CSU Vet CE. Nestled up against the Rocky Mountains in our new State of the Future facility, we invite you to experience what we call CE Elevated. We'd love to see you in one of our future on-site, online, or blended courses. Check us out at www.csuvetse.com. Now, please enjoy Endoscopy Talks.
Good evening, ladies and gentlemen. It's my pleasure to have this opportunity to welcome you join this webinar. I'm Dr. Zhang, the president of Taiwan College of Veterinary Surgeons. Many thanks to Carl Storz Endoscope and Dr. Monnet for organizing this course for TCVS. This webinar, I believe, will inspire participants to have deeper and better understanding of clinical application of ICG in small animal minimally invasive surgery. I would like to welcome you again and wish you have a successful webinar, and hope all participants will learn more and enjoy this course. Thank you everyone. See you.
Hi everybody, I'm Jack Chu. Today I'm glad to say thank you for TCVS and Carl Storz to organize this webinar. It's my honor to introduce the speaker, Dr. Eric Monnet. He is my mentor in minimally invasive surgery, and he is currently a professor in small animal surgery at Colorado State University. 10 years ago, I went to Colorado and joined his continuing education courses in laparoscopic surgery. I'm very impressive of his passion in education, practice, and excellent study. He also went to Taiwan several times to give us a very good lecture and a workshop at Yeka Taiwan in Zhanghua. So thank you for Dr. Eric Monnet, and stay safe. In these years, we're ready to organize an association of veterinary endoscopy society in Taiwan. So welcome to join us, and see you soon. Thank you, bye-bye.
Hello, everyone. I'm David Tweed at Colorado State University as part of the Translational Medicine Institute. Welcome to the special edition of Endoscopy Talks. I'm going to turn the session over to Dr. Eric Monnet.
Good morning or good evening, and depending where you are in the world, but thank you again from my friends from Taiwan and Carl Storz and the TMI CSU for organizing this and inviting me. And we're going to be talking today about fluorescence imaging and its all its clinical applications. I mean, it's a fairly new topic for us in veterinary surgery. It's a topic that has been going on into the human field. And if you look onto a website, if you do a PubMed search about just doing photodynamic diagnosis, you can see here, I did that study, that search in 2015. There were barely 7,000 publications. Now in 2021, we are up to 10,540 publications. Shows you how important is this topic. And it's mostly used, like I said, in the human side. And but there are a lot of very good application for us, okay? And hopefully during this webinar, you're going to see the benefits and all the things you can gain from using this fluorescence imaging technique to improve your diagnosis, improve your surgical technique, and improve the outcome of your patients. So not only you have a lot of publications on PubMed, but you're going to find a lot of books that are also being published on that topic. Okay, those two books are the ones that I've been reading the most, and I'll be referring to those books or making comments coming from those books during this presentation. And the one you see here on the left, the imaging and visualization in the modern operating rooms, you're going to see in this book that they show how fluorescence imaging can be used as a bridge between advanced imaging and the surgical field. Because now we do a lot of advanced imaging like contrast CT, CT, lymphangiogram, CT angiogram, or MRIs. But then when you're in surgery, those images do not translate very well to what we're seeing in the surgical field. So with this fluorescent technique, we can really bridge this gap in between those advanced imaging, diagnostic imaging, and what we see in the surgical field. So very, very important. Also, the other book, The Fluorescence Imaging for Surgeons, is not only talking about this bridge, but also talking about all the different applications that exist in the human field right now. And a lot of those applications can be translated to what we are doing after we understand better how to use this technique, this technology. If we go back a little bit into what is fluorescence imaging, what is fluorescence? By definition, fluorescence is the emission of light by a substance that has absorbed light and another electromagnetic radiation. So basically here, what you need is two different components. You're going to need a special chemical substance in the patient, and then you need a special light source that's going to excite this substance before it can emit some fluorescence. So that's a key element here. You need to have the right light source for the right substance. So those two have to match together. And then if you go back to your old classes on physics or chemistry, whatever you studied, I mean, when an electron is being excited with lights, it moves outer layers of the nucleus here. And then when it goes back to its normal state, it's going to emit some light, okay? And that's what's happening with fluorescence. So that light that's being emitted by this electron going back to its normal state is at a different wavelengths. And that's a trick that we're going to use when we use fluorescence here. We're going to excite the substance at a certain wavelength, and then we're going to read the light that is emitted by this electron at a different wavelength. So that's the whole trick here of the whole system. So you're going to need a system that can send the correct wavelengths, but also that can read the lights at a different wavelengths here. So that's very, very important. So the system that you're going to do should be able to do this. So what is going to happen here is your light source has to be well calibrated, I mean, and has to be at the perfect wavelength. So different light sources are going to produce different wavelengths, and the one from Karl Storz, which is the one I'm using, has different setups. So make sure the one you're using is a correct setup. So you can see here on the screen, you can see ICG, because that's what we are using most commonly in the veterinary field, or at least personally, what I'm using most commonly is endocyanine green. So now the light source is going to produce the perfect light wavelengths that is going to excite whatever substance, whatever tissue is in our field. And then we're going to read it through an endoscope. And then in the camera head here and within the endoscope, you have a set of different filters that are going to isolate the wavelengths that we want to see. And that's how you get on your screen those nice, beautiful images of fluorescence of different structures, whatever you're going to study. So there's a lot of complex physics behind all this, okay? And when we do the surgery, we don't have to think about all of this, but that's what's going on behind the scene. And now they are getting more and more sophisticated in their technique, because right now, with this technology, you can work either with the special wavelengths with ICG, or you can work with regular light. So you have to switch back and forth in between those different setups, but you cannot use them together. Now, and which is very important to remember, and you're going to see some videos about this, because usually when you use the ICG wavelengths, you cannot really do surgery with it. You have to switch back to the normal light to be able to do the procedure. So we have to switch back and forth constantly. Now, the new technology, and especially the one that's been produced by Karl Storz now, it's called the Rubina, allows you to work with both the regular lights and the special wavelengths together. So you can do surgery without switching back and forth constantly, but you have superimposition of the two images together, which is a nice improvement here. So obviously, for the talk today, we'll be talking mostly using endoscopy to do this. So we're going to be able to do the procedures during laparoscopy or during thoracoscopy. But also you can use it for open surgeries, which I've been doing it also. And you can use the same tower, the same camera, everything the same, but then you're going to use an exoscope like the VTOM 2 for ICG. And now while you're doing your open surgeries, you're going to be able to use that technology to visualize better the structures that you're looking for. And that is very beneficial, for example, to detect lymph nodes, sentinel lymph nodes through the skin. That's getting a huge application now. And we are starting here with our oncology group to start to look for some sentinel lymph nodes for mast cell tumors. And we can read some of these ICG fluorescence through the skin to a certain depth. So that's another application of it. I'll mention it a couple of times in the presentation today, but remember that that's another application. So you have plenty of different imaging systems that exist, okay? And that list is not complete. I'm sure I missed a few, okay? That's no question about it. And the one that I'm using here, that's the one I'm mostly familiar with, is the one from Karl Storz, the D-Light, P-Light images. And that's the one I just showed you a first image. And like I said, now we have the new technology, like the Rubina technologies that allow a superimposition of both. So that's part of what's out there, but definitely you'll have to pick what technology you want to use. Now you can see on the screen here, you have different colors, different modalities, different systems. The color coding, like the blue pictures you can see on the Storz monitor versus the green picture you can see on another monitor, it's just a computer artifacts, okay? The computer codes the picture and put the image as a blue light or as a green light. That's pretty much a software choice. It's nothing, it's not because ICG is fluorescent in green or is fluorescent in blue. And then you can use also other filters on top of this. That's going to help you improve the contrast, visualize better different structures. So it's another set of filters that are into the system that is going to help you visualize better the different structures. So if you go through the system here, see what's happening. If you look at a regular tissue with a regular white light, that's a picture you're going to see. So here you can see some bile duct, okay, with the liver in the background. And you can see the cystic duct here with the cystic artery in the middle of it, okay? And that's the image you will get during laparoscopic cholecystectomy with regular light. Now, if we use the same image, okay, but now we just put the excitation filter on, which means we're going to use the ICG light by itself, okay, without filtering the pictures and without injecting ICG, that's the image we're going to get. So it's very blend image if you want to. You don't see very well structures because now none of those substances, none of those tissues are going to emit fluorescence imaging. So that's a nice thing about this excitation filter. It's going to produce a wavelength that is not going to induce fluorescence from the background, pretty much. Okay, so that's the important step here. And now if you do the same image with the excitation filter and the emission filter now, so you put the camera with the correct filter, so you can see now the same image, the backgrounds kind of disappeared, and you see only the structures that have the ICG, that the substance that is producing fluorescence. So you can see a little bit in the background the blue colors of the liver, because the liver has a little bit of ICG. And you can see some of the structures that starts to show up here because they are collecting ICG. So you can see how this technology allows you to isolate different structures, which is going to improve what we're going to see into our surgical field. Okay, so that's the whole principle behind it. So now we're going to use in surgery near infrared light. Okay, the reason why we want to use near infrared light is because we don't see it ourselves. Our eyes are not going to see, it's out of the visible light for us. Okay, if you look at this spectrum here, the visible light stops around 700 nanometers. And when we talk about near infrared, we're going to be around the 800 nanometers. So we should not be able to see this light. And then ICG is going to emit a little bit of higher wavelengths out there that the camera and the computer are going to be able to pick up. So when we are in a near infrared light, we're outside of our spectrum here. So that's on purpose, we're doing this. And also the other reason why we use near infrared lights is because all the different components of the normal tissue in any bodies, okay, in any animals, are going to be able to produce fluorescence if you excite them with the correct wavelengths. So you can see here in these charts the different structures you have in a normal body, like collagens, elastins, okay, and other structures like tryptophan. If you excite them at those specific wavelengths, they are going to emit some fluorescence. So if we go into the near infrared, which will be somewhere in the 750, 800, we're going to be completely away from those structures. So none of those are going to emit anything. So that's why when you just use the excitation light, you don't see anything, because none of those structures are going to produce anything. So that's the whole trick there. So now, since we are completely outside of that range of wavelengths to excite anything, we need to use a special fluorophore, which is basically a component, a drug that is going to be able to produce a fluorescence light, a fluorescent light with the correct excitation, okay? And so you have a whole big, huge spectrums of those different fluorophore. And I just put a limited list there of those fluorophore. I'm sure there is way much more than that. But it's just an example. And it depends what you want to study, okay? And you can see, for example, the 5-ALA, which is the amino levulanic acids. Those ones are used very exclusively for study in the brain. If you're interested by neurosurgeries and surgery in the brain, they're going to use this substance that will go directly to some specific substance in the brain and bind to those structures. That's going to help isolate tumors and perform a better surgery and removal of some of those tumors in the brain. Some of the components, for example, are going to be better for bladder, okay? And I'm going to show a few examples here. And then you can go down the line here. Some of them are more or less specific, more or less fluorescent, like methylene blue or fluoresceins. If you get them with the correct wavelengths, you're going to get them to do something. But again, for us, the one that we use, I think, pretty much exclusively in the veterinary field, for what I could find in publication or talking to different people, is indocyanine green. Okay, so that's the one I'll be talking the most, because that's the one I have the most experience with. And then you have other substances here that are mentioned that are not used very commonly. So like I said, the amino levulanic acids is used in the brain, for example. Okay, that's definitely the most common indication. So if you heard about the paint and painting brain tumors, that's what they're doing here. And then they can isolate very, very small structures, very, very small lesions with this technique. They also use this different fluorescent structure here, also in the brain, to help visualizing their structure. This 5-ILA is also used for lung and trachea and larynx because they can use it as an inhalant. So they put that in inhalator and make the patient breathe those substance that are going to bind to some specific cells into the lungs, the trachea, and the larynx, and allow you to visualize better some lesions of inflammation, some tumors in there, because it binds to those protoporphyrin structures and then emit fluorescence there. In the bladder, it's a great application in human, okay? Because when you have small bladder tumors, that happens very commonly in humans, they can use these other hexaminolevulinic acids in those patients. They have different ways to deliver the drugs. They can inject it into the bladder by itself, and usually they let it sit for an hour, and then they go with a flexible endoscope, and they are going to visualize very, very small tumors, especially if you have carcinomas, for example, because this drug is going to be incorporated, or it will accumulate in cells that are dividing extremely fast or extremely quickly. So tumors are good to do this. So then when you go in with your scope and turn on the excitation light, you're going to see, again, binding to those protoporphyrin X structures, you're going to see the lesion. So you can see here in this patient, in normal light, obviously you see this little nodule here, it's pretty obvious, so you don't need anything. But then if you turn with your special wavelengths to excite the drug that you injected, obviously we see these little polyp lesions here, but you see next to it, there is another lesion that you could not see on the normal light, okay? So that's a nice advantage of this technology, is that you're going to be able to isolate and visualize much smaller tumors that you would see without those structures, without fluorescence. So that will improve the quality of your diagnosis in your patient. And like I said, the drug that we use most commonly in the veterinary field is endocyanine green, okay? And my source of endocyanine greens come from Acorn, and there is probably other distributors, other company making it. And this endocyanine green comes into a powder, okay? And it needs to be reconstituted with a sterile saline solution, okay? And it's not purely saline, it's kind of water by itself, sterile water. And it's important to use the solution they give you to reconstitute the powder, because if you don't, it may not dissolve very well. So it's important to use that. And they always recommend to use it within 6 hours of reconstitution. So when I'm going to use it, I reconstitute it just before I'm going to use it. And then I'm just not going to reuse it anymore. I mean, there is probably some problem with conservation of the ICG, the risk of contamination and infection, but also probably losing some of its fluorescence capability over time. So that's the downside of it. After you open a vial and reconstitute it, you're going to use whatever you need, and then you have to discard it. We use very, very small amounts, okay? And that's one of the topics of discussion right now, is how much to use, and we don't really know, and we have a tendency to use too much. There is one phenomenon that will happen if you use too much endocyanine green. It's called the quenching effect. It's going to absorb all the light without producing too much fluorescence, and everything will look very dark, okay? So you have to find the correct dosages, and that's a lot of people are doing research on that in the veterinary field, is to find the correct dosages and the timing, okay? That's another also very important thing. I will talk about it a little bit later. So now when we use ICG, we're going to be past the visible light. So we're going to excite it with a level of with a wavelength of 805 around that. And then ICG is going to emit a light around 835 wavelengths. So we're going to be able just to separate that, and you can see we're completely away from the rest of the other structures here. So we're going to be able to isolate specifically all the structures that have ICG in it. And the good thing about this technology is that you can detect, according to human research, you can detect structures all the way up to 1.5 centimeter deep into tissue. And I visualized that. I've experienced that not a long time ago in a dog with a chylothorax. We used it and we could not really see the thoracic duct right with the normal light. And then after we injected ICG, we could see some fluorescence through the fibrous tissue. And then we started to dissect into the caudal mediastinum. And we were able then to visualize much better the thoracic duct. So we could see this ICG fluorescence to at least 0.5 centimeter to 1 centimeter of tissue. So that's one of the big benefits of ICG. You can see it through a fairly good amount of tissue into your way. So this ICG has been used a long, long time ago, okay, to study different liver functions and stuff like that. And ICG is eliminated by the biliary system, okay? So that's something important to remember, because since it's eliminated by the biliary system, it's going to be very, very useful, for example, when we do cholecystectomy, okay? So you can inject it intravenously, or you can inject it directly into an organ, which I've done also, which I've been doing, for example, when you want to see a draining lymph nodes from a specific tumor, you can inject the ICG just around the tumor, and then you can track the ICG through the lymphatic system, and you can track it to the first lymph node that is draining this tumor, okay? So that's how it's used for sentinel lymph nodes. So it's binding to plasma protein, it's transported into the blood this way if you inject it IV, and the half-life is pretty short, okay? It doesn't last very long, okay, at least in the vascular system. When it starts to get excreted into the biliary system, then it accumulates into the biliary system, it's accumulating into the liver. So then it stays there a little bit longer. It depends how quickly the bile is eliminated, but within the blood, it goes away very quickly, okay? Again, it's probably affected by the liver function, okay? If the liver function is not the best, or is affected, or there is some liver disease, probably the ICG won't be eliminated as fast. And like I said, I mean, excitation wavelength is around 805 nanometers, the emission wavelength 835, so it's fairly easy to separate them. So the dosages that are recommended for that after you reconstitute the ICG solution is around 0.1 to 0.5 milligram per kilogram of body weight. And talking to some humans, some specialists in the human field, they have a tendency to err always towards very, very low dosages. So my recommendations will be to start with a dose of 0.1 milligram per kilogram, especially if you use it as an IV injection, especially if you want to see the gallbladder, for example, you can do that. When I inject it into a lymph nodes for a thoracic duct, I will go to a higher dose. Usually what I will do when I try to visualize thoracic duct, I inject 2.5 milligram, no matter what the size of the dog is. And you can repeat those injections many times if you have to. So it really depends if you inject into a lymph node or if you inject IV for the amount that you're going to use. So what are the applications of this, okay? For oncologic surgery, it's huge, huge field of application there, okay? And if, for example, and Dr. Holt and Dr. Runge, when Dr. Runge was still at the University of Pennsylvania, they've been working into detection of lung tumors, okay? And apparently it's a huge applications for human field. They are going to inject the endocyanin grain into the patient, and those endocyanin grains is going to leak through the capillaries within the tumor, because capillaries into the tumors are not always intact. So they use this artifact, and then the endocyanin grain is going to leak. You're going to tell me if it's a big, huge tumor, we don't need to do that. I agree. But in humans, this idea of this research was based for human, because in human, they have much smaller tumors when they are diagnosed. And sometime again, you're going to see them on a CT scan, but you may not see them in surgery. They might be hard to visualize in surgery. So that's when it's used as a bridge to visualize the tumor during the surgery, and just to identify it and correlate with what you see on your CT scan or MRI images. So you can see here in this case, he had this dog had a lung tumor. They injected ICG intravenously, and you need to inject it many hours before surgery. Okay, we don't know how many hours before surgery, but you need to inject it a long time before surgery. And then when you go in, you're going to see this nice fluorescence here in these cases, okay? Another technology that is used in human also is instead of using IV injections to identify the tumor, for example, under CT guided, what they are going to do also after they see the tumor on CT, they're going to go CT guided and inject fluorescein, not fluorescein, but inject directly ICG into the tumor. And then when they go to surgery, they're going to see that areas of fluorescence again and use it as a bridge again to better visualize their tumors and do the appropriate resection. Also, a big field of application for us, and our oncology group here is getting into this type of ideas here, is for identification of sentinel lymph nodes, okay? You know, that's a big staging point here. If you can identify tumors and metastasis in the sentinel lymph node, which is supposedly the first lymph nodes draining the tumor, it's a very, very important prognostic indicator, okay? So then you can use your ICG, identify the lymph nodes, and then biopsy specifically those lymph nodes, okay? So that's going to be very beneficial and really targeting the appropriate structure there that's going to be fluorescent. If the lymph nodes become fluorescent, it doesn't mean it's a metastasis. It just means it's a first lymph node to drain that tumor, okay? So, and the nice advantage of using endocyanin grain, for example, is that there is no radioactivity, so there is no safety issues. Because in the past, they were using radioactive agents that they were injecting in the tumor and then track it down with gamma cameras or some detectors of radioactivity, which is always a big concern for the people in the OR, for the patient. Now using fluorescence imaging, we don't have to worry about radioactivity anymore. And also the fluorescence, like I already mentioned, you can detect it to at least a centimeter deep. So it is then definitely very beneficial in those patients. And you can use it during laparoscopy, thoracoscopy, or as an open surgery with a VTOM, for example. So here you can see in this case, and that was a very interesting case. It was a dog with a lung tumor, and I injected around his tumor, and I injected 2.5 milligrams of ICG all the way around the tumor and waited a few minutes. And then when you look at, we were trying to track the hilar lymph nodes, and we could never see any hilar lymph nodes. And then we start to look in the mediastinum, and you could see here, you could see on the white image here, the white light image, you can see the cranial mediastinum. You can see some structures there. And then when you turn the fluorescence imaging, you can see that the ICG accumulated in 2 or 3 lymph nodes there. And there was still nothing at the hilar level. So it's really, really interesting to visualize this and help us target those lymph nodes. So we biopsy those lymph nodes There were no metastases in those, but at least it helped us towards finding those structures here and identified them. We may not have been able to recognize them in the white light. Also for lymph nodes in the stomach, for example, you can inject, if you have a tumor in the stomach and you want to isolate the first lymph node again, you can repeat exactly the same procedure. So you can do it in any structures you want, okay? There's nothing very, very difficult there. After you understand the principle, you can do that. Here is, for example, for anal sac, okay? And that was an interesting observation we made in this case here. We injected the endocyanine green around the anal sac, and then we went into the abdomen with the scope, and we could see all those lymph nodes lighting up one by one into the pelvic canal, way before we got to the iliac lymph nodes, okay? So, and it was interesting to see over time, and it happens pretty quickly, okay? Within 5 minutes, all those lymph nodes light up one by one, and you can also see those little lymphatics. So you can have a very nice, precise image. So you can go and again biopsy those lymph nodes at the same time you're biopsying or removing iliac lymph nodes. But that's another very interesting observation there that we could see in those patients. So as you can see, I mean, it's great potential here to identify lymph nodes, and we need to develop that technology here. It's very user-friendly, okay? Very, very limited toxicity if you inject it into the subcutaneous tissue around the tumor. And again, I mean, the depth of penetration is a centimeter. I mean, it sounds a little bit limited, but it's really interesting technology to use to detect lymph nodes. So definitely big application here in oncologic surgeries, not only for detecting tumors, but metastasis. Another here application that was done in those cases with a liver tumor, okay? What they were doing in those cases, as you can see here, I mean, you can see in white light, you can see some obvious lesions here on there, and you don't know what those lesions could be. But after they injected ICG IV in those patients and used the fluorescence again, you can see this little halo that happened around those structures here, which is a very strong indicator that capillaries are leaking. If capillaries are leaking, that means it's probably a tumor doing this. So it helps characterize those lesions up here versus those one didn't seem to do much. But also this big structure here that's not necessarily very obvious turns very fluorescent here. So that helps identifying other structures that you may not have seen without using fluorescence imaging. So again, it's improving the quality of the diagnosis here. So again, detection of tumors, detection of metastasis, but also now they're working towards targeting specific tumors. So not only they are going to use a fluorophore now, but they are going to use fluorophore that are linked or attached to a ligand. So this fluorophore is going to bind to some very specific receptors, okay? So now if you use the correct agent and the correct linker and the correct ligand, you're going to select different structures that you can isolate. Either it could be a cancer, inflammation, or infectious disease, depending what kind of binding agents you're going to use. So that definitely improved dramatically the sensitivity of your test and help you isolate just inflammation from cancer, okay? Because now your lymph nodes will become fluorescent only if they bind to the structures that you have, to the binding agents that you've been using. So it's becoming more and more selective now and more specific. I don't think anybody ever used this into a veterinary field. I'm pretty sure some people are going to start to do this very soon, okay? And that will definitely improve the quality of our diagnosis, because now in human, what they do, if you're diagnosed with a primary lung tumor, they're not going to rush to surgery right away. They're going to do all kind of investigations, CT scan, and try to do the best staging they can, trying to figure out what's your prognosis and what is the best approach for the patient. So if we start to do all of this, we might improve again our staging capabilities and improve our prognosis and give better information to owners down the road. So here you get an example of an injection of a endocyanin green around a tumor, a lung tumor in the dog. So what I do, I use an epidural needle. So I visualize the tumor. You can see the tumor is not very big here. And I use one lung ventilation. So that's why you don't see much motion. And then you can go with your epidural needle and seat it right next to the tumor here. And obviously it's important to get into the lung parenchyma and not through the lung parenchyma, okay? And it's important to stabilize very well the tissue when you do the injection. So you can see I have a probe underneath supporting these lungs. And in this case, I injected 5 milligrams of ICG. So I did 1 or 2 injections. So you can see here, I'm doing the second injection. And you can do those injections around the tumor, it doesn't matter, I think. And you start to see ICG accumulating here into the lungs. And it's important when you remove the needle, make sure there is no ICG leaking, okay? Because if ICG start to leak, then it's really, really hard to interpret the images. I'll show you some pictures where it leaks. So we always have a little bit of leakage, it's a given. And you can see now we turn the infrared light and you can clearly see the fluorescence. And you see in the center, the quenching effect. It's dark, it's black, because there's so much ICG in the center, it's doing the quenching effect, okay? So that's it been injected. And that's what happens if you don't pay attention, okay? If you have leakage, then it goes all over the thoracic cavity, all over the pleural space, and then it's really, really hard to identify anything. So very, very important here to have a good control how you're injecting this endocyanin green into the tissue, because if you don't pay attention, you're going to ruin the whole image, and then you're not going to understand very well what you're doing. You're getting those beautiful images, but they are not useful for your patient. So if we go back to our case here, so we injected it, and now you can see, we start to see a little bit of ICG accumulating here, and that's where the hilar lymph nodes is. Okay, so pretty quickly here, within a few minutes, the ICG diffused through this lymphatic system and went to this hilar lymph node. So then we continue with our resection of the lung tumor through thoracoscopy. So we applied the stapling equipment right at the base here of the lungs. And after we completed this lung lobectomy, then we went back to the cranial mediastinum, went back to the hilar lymph nodes to see if we see anything different. And then we biopsied every lymph nodes we could see that were fluorescent after the procedure. So here you can see the post-op resection here of these lungs. So you can see here on these images, you get a little bit of fluorescence on the stump, which is expected because some of that ICG probably went into some alveoli, went into some bronchi, and then went all the way up to the stump here. So don't panic if you see fluorescence in your resection line. Doesn't mean you have tumors left there. It's just normal ICG that diffused there, okay? So that's expected. So now you can see this thing real time. So you can see very intense fluorescence here. And then we keep looking around. And when you start looking around, you have to be careful not to touch too much the tissue, okay? Because you have a little bit of endocyanin green, and you can see here nicely this hilar lymph nodes is nicely fluorescent now. And if you look with real lights, you barely see it, okay? And then we went into the cranial mediastinum, and again, you could see lymphatics, and you can see lymph nodes into the cranial mediastinum. So we went in and biopsied those. You can see it a little bit here because it's accumulating endocyanin green, so they turn a little bit green, okay? but you can clearly see them now with the fluorescence. So we can clearly go and biopsy each of those lymph nodes. None of those turn out to be metastatic in these cases. So again, it's not because they are fluorescents that they become metastatic. So see here, it took around 10 minutes to get those images. So it's the time it takes to do the long lobectomy. So inject your ICG, wait a few minutes before you do the long lobectomy, because you need to let the ICG diffuse. So as soon as you start to see some ICG around some lymph nodes and some lymphatics at the hilus, then you can do your long lobectomy. And then you can keep evaluating the rest of the thoracic cavity here. And so when we do it this way, we can only see lymph nodes on the side of the tumor. We don't see the lymph nodes on the other side, okay? But I mean, since we do it into lateral recumbency and intercostal thoracotomies, we don't see the entire thoracic cavity this way, but definitely it's really improving the way we can diagnose this. Another application is using ICG to do lymphangiogram. Okay, like I talk about the bridge in between advanced imaging and what we see in surgery, that's a very good application there. I don't know if you do CT lymphangiogram before your thoracic duct ligation for chylothorax, but that will be a great application here, okay? So either you do thoracotomy or thoracoscopy, doesn't matter. You can use the fluorescence for both technology, depending what kind of scope you're going to use. And traditionally, people are using methylene blue, but again, now I am using endocyanine green, and other people do. Dr. Steffi from Davis created a nice publication in 2018 about this and documenting the technology to use that and the techniques using mesenteric lymph nodes. And I like to use mesenteric lymph nodes to do that because it's a very easy lymph nodes to reach. You can reach it with laparoscopy easily, and you can inject into one of those mesenteric lymph nodes, and then you're going to visualize inside the thoracic cavity the thoracic duct. But also the nice thing, also you're going to visualize the cisterna chyli, okay, which is if you're one of the person that likes to do cisterna chyli ablation, that's going to make it very simple. And the good thing also with this technique is, since you see on your CT lymphangiogram, you may see several branches with this endocyanine green and fluorescence, we're going to visualize those branches also. So you can really clearly see that bridge. So here it is in one case that I did that had a chylothorax. I did a laparoscopic assisted injection into the lymph nodes. So the patient is in lateral recumbency, and we are on the right side of the abdominal cavity, because remember in dogs, the thoracic duct is on the right side. So I went into the abdominal cavity with laparoscopy to figure out where the mesenteric lymph node was. And then we pull that loop of intestine. So you can see here, you have the cecum and ileum, and you can see that big lymph nodes here, which is always very prominent. So then with a tiny 25 gauge needle, I inject endocyanine green into the lymph nodes. And like I said, I inject 2.5 milligrams to start with, and you need to do the injection slowly, okay? You don't want endocyanine green to leak all over the place, because if you start to get it in your fingers or all over the place, you're going to transport it into the thoracic cavity. So inject slowly, and what I mean slowly, it's over a minute, okay? So inject a little bit, you're going to see the lymph node swell, so then you let the lymph node goes back down to its normal side, inject a little bit more, and you can see very quickly, you can see it on this image here, you start to see lymphatics. You can see some green, endocyanine green going into the lymphatics. And so when I do this, I place already all my cannulas in the chest, or I open the chest before if I do it open, so to make sure I'm ready to look at the thoracic duct, okay? And then when you're inside of the thoracic cavity, you remember the thoracic duct is located dorsal to the aorta, okay, ventral to the vertebral body on the right side in dogs, and you have the pleura covering it. and you have patient with chronic chylothorax, this pleura could be pretty fibrotic here. And so sometimes you may have a lot of depth to go through to see the thoracic duct. That's when the endocyanine green is really, really useful. And then with endocyanine green, you're going to see if there is more branches going up, and then you can extend your dissection even more towards the eozygous vein to be able to do an en bloc ligation if you have to. Also, the nice thing about using the endocyanine green is when you do your dissection, especially if you start to do it with thoracoscopy, you don't want to damage the vertebral arteries, okay? So the endocyanine green and the fluorescence are going to allow you to see those vertebral arteries going over the thoracic duct, because that will be areas where fluorescence are not going to be as bright. So you want to avoid those arteries. You don't want to make them bleed. So if you make them bleed, you'll have to control them. So you can see here in this case where it's a thoracic duct, and we are in the caudal part of the thoracic cavity in the caudal mediastinum. And you see here we're just doing dissection there of the caudal of the pleural surface. And you can clearly see the vertebral artery here. We see it without fluorescence, but you can see when we put fluorescence on, the fluorescence stops over this vertebral artery. So it's a nice way just to visualize those structures. And then we can continue our dissection here in between vertebral arteries, okay? So here you can see that's what I was talking about at the beginning. You have to do some of the dissection with white light. Sometimes we can dissect like here and under infrared light, but it's always hard to do. So we switch back and forth all the time to be able to do the dissection with white light, so we see a little bit better. Now with a new technology called the Rubina technology, you won't have to do this anymore, okay? And you can see here, this thoracic duct is a couple of millimeters deep into the tissue, so we can see pretty well the thoracic duct there, and then we're going to continue our dissection right here, okay, and visualize very well the thoracic duct in this case, and then that's going to be a nice dissection here, and then I go with a right angle forceps to completely isolate it. On this dog, we only had one thoracic duct, okay, so that was pretty straightforward to continue the dissection here and isolate it. Here you have another case, okay, where it's a little bit thicker tissue, so I'm using some of the cautery, and obviously we've got a vertebral artery here, so you can control that and visualize it, okay? And you're going to use the vessel sealant device. So here we had a little bit of fibrosis. We could not see very well this vertebral artery, but then you can control it very easily and take care of the problem here. But we could see very well the thoracic duct again with the fluorescence in this patient. So here we're continuing our dissection with the right angle forceps. And again, you have to be very gentle when you manipulate those thoracic ducts. You don't want the ducts to be perforated, because if you damage the ducts, ICG will leak all over the place, which will not be very nice for the continuation of the surgery, but may not be a good outcome for that patient. So you can see here we use a combination of vessel sealant device, electrocautery, blunt dissection to visualize the thoracic duct. So you can really see here, I'm going to go back a little bit on the image. You can really see where we haven't dissected the thoracic duct. The image is pretty blurry, not very clear, but you can see the thoracic duct through the mediastinum very caudally. But now that we have the dissection pretty well done, we have a pretty clear, crisp image of the thoracic duct down here. So now that we have that completed, we're going to be able to finish the dissection and then put clips on it. So you can see here on this other case with very severe fibrosis, you can see this dog had a very chronic chylothorax. So we're starting our dissection just dorsal to the aorta here. And we're going to be able to go through this thick fibrous tissue there and dissect our thoracic duct with that. Again, in this case, I use 2.5 milligram of endocyanin green. And like I said, this will diffuse pretty quickly. So if you're losing your image because you don't have enough endocyanin green, don't hesitate to re-inject it. Okay, you can do several injections if you have to. So there is no problem to do several injections if you want. Okay, so here we go with the vessel sealant device to continue dissecting around the thoracic duct. I will not seal the thoracic duct with the vessel sealant device. They may not seal very well, but you can use it to continue the dissection across the coronal mediastinum. So now that we have this thoracic duct well isolated, you can see it now well isolated. You can go with your clips and clip this, okay? And so we're going to clip that. You can see the azygous vein on the back there. So now we're putting clips, okay? And then what we're going to do, if you are patient enough, you're going to see the fluorescence going to accumulate caudal to your clips. So the lymphatics and the lymph is the chylous fluids keeps accumulating caudal to your clips, but cranial to your clips, the fluorescence will disappear, okay? Which is always a good sign. That means you've ligated the correct thoracic duct and there is no more fluorescence cranial into the thoracic cavity. Something I've noticed too, if you do the surgery for long enough, I mean, if your dissection takes a long time, you start to see fluorescence accumulating into the chylous effusion into the pleural cavity. So I've seen that happening in cases. So this chylous effusion, which is leaking somewhere, starts to accumulate into your pleural space. So you start to see on the right side here of the screen, the fluorescence starts to disappear a little bit. I mean, it's pretty quickly here, but if you waited another few minutes, that fluorescence cranial to the last clip will completely go away. So now you have your clips well placed, okay? In the location there, we can confirm with endocyanin green, we have everything well clipped, okay? And here we go. This case, you can visualize all those different branches, okay? That was a very weird case. So we went into each of those branches one by one and clipped them one by one. I'm not sure with our naked eye, we will have seen it that well, okay? And this one is leaking a little bit. So we're putting the clip caudal to the leak. So just to make sure we're closing it correctly, but we went after each of those little branches here. And now you can start to see there is no more fluorescence cranial to the clips. It starts to disappear. So which means we got all those branches. I don't know if we'll have been smart to go with the vessel sealant device to dissect through all this tissue here, but you can see this patient have all those different branches there, which is, again, what I was talking about, the bridge to in between advanced images and surgery. Like you can see on this case here where we did a CT lymphangiogram, you can see 3 big branches in this dog, in his caudal mediastinum dorsal to the aorta. And when we went to surgery, we could see all those branches, okay? I don't know if I would have been able to appreciate that without using the fluorescence technology. And I know a lot of people are doing en bloc ligation, which is also what I like to do. So doing en bloc ligation should take care of all those branches, but it's always good to be able to visualize the caudal mediastinum and make sure we got everything. Now, something that can happen is while you do your dissection, you might tear the thoracic duct, okay? Or you might tear the very cranial part of the cisterna chyli, which is interesting to notice when you start to use fluorescent stuff, you're going to see the cisterna chyli protruding through the diaphragm. So you have to be careful not to go too far caudal and dorsal when you dissect the thoracic duct, because you can damage the cisterna chyli and then it will leak inside of the chest. And if you have leakage like here inside of the thoracic cavity, it's really hard to identify any structures because now the whole thing is completely smeared with endocyanin green and everything turns to be fluorescent. So it's really, really hard. I was lucky in this case, it leaked after I put the clip, so I was able to clip the thoracic duct correctly. And then we had a bit of leakage after that, and we reapplied another clip, a bit more coral to stop the leak. But if it's leaking, it's a problem. Another thing that happened to me not long time ago is when I injected the endocyanin green into the lymph node, some of it went IV, okay? Which can happen, you know, next to a lymph node, you always have big veins. So some of it went IV, and then when we went into the chest to look for it, we could see very well the thoracic duct, but the whole background was kind of fluorescence because the endocyanin green diffused in all the tissue. So it's kind of not a big issue, but that could create some kind of a problem there because it might be a little bit harder to visualize the structure. And then on this case, after I injected the endocyanin green, we did the thoracic duct. We saw very well the cisterna chyli. So you can see it here in the top left image, the cisterna chyli becoming very fluorescent. So went in toward the cisterna chyli to do an ablation, and then you can see the endocyanin green that was pouring out of that cisterna chyli there. So it helps doing this also. Another great application that I'm working on right now is to use fluorescence imaging for biliary system, okay? And it's been used in human now for quite a long time to do near-infrared fluorescence cholangiography to help identify the biliary anatomy during laparoscopic cholecystectomy. You know, when you do cholecystectomy, the big concern is to see very well the cystic duct, but see also very well the common bile duct and the hepatic duct. So you don't occlude the common bile duct or hepatic ducts. You're only occluding the cystic duct. So in human, it's a big deal because common bile duct and cystic duct are very close from each other. You can see in those images on the left column, it's all real white light color. So you can see the common bile duct labeled CBD and the hepatic duct labeled CHD are very close to the cystic duct labeled CD. So it's a very, very common mistake in human to clip the cystic duct and the common bile duct. So using endocyanin green helped tremendously visualize those structures and avoid damaging those structures. So you can see on the right column here, pictures with ICG. So obviously the liver picked up the ICG, but also the biliary system. So you can see here now, you can visualize correctly all those structures much better. At the bottom right picture here, you can see the bile duct, the cystic duct, the common hepatic duct, and the common bile duct. So in human, they are using something like 2.5 milligrams of ICG IV, and they give it 60 minutes before surgery. And that's enough time to go and accumulate into the biliary system, okay? So we're doing some research right now and some projects, and we're not the only ones. Some other people are doing also some research using ICG for biliary surgery. And you can see here in one of our research dogs, we injected 5 milligram IV, which is too high now. I mean, I will use way much less than that now. And we waited 40 minutes. And within 40 minutes of injection, we could clearly see the common bile duct and the cystic duct. So the common bile duct is at the bottom here on the bottom left picture. And the duct going more dorsal here is the cystic duct. And then here on the top left pictures, you can use different frames, different filters that could help you identify even better your structures with ICG. So at the bottom right, you have the white light picture, you have the white with infrared light picture. Same thing on the top left, you have the infrared light picture with special filters that you can use. So you can see how well it's helping you visualize those structures. In these dogs here, they were very obvious, okay? I mean, they're not always that obvious, but that's definitely a nice application. So now, what we're doing in the clinics and talking to some human surgeons, we're going to use barely 1 milligram of ICG IV, and you can inject it 40, 50 minutes before surgery. So usually what we do now is inject it just at the time of sedation of the patient. You inject it as soon as he has an IV catheter. By the time your patient is induced, clipped, and in the operating room, it's going to be around 40 minutes. And that should give you a beautiful view of your biliary system. Okay, so that's definitely a great application here. Also in human, it's used, for example, for detection of bile leakage. And if when they do liver lobectomies in human, it's not like in dogs where we have nice lobes well isolated. Okay, in human, it's one big blob and they have to finger fractures through it. So sometimes they may have bile leakage, and then they can use this technology to find the leakage. We could do the same thing in dogs. I mean, sometimes we have bile leakage after liver lobectomies, but it could be used also in trauma cases. It happens, you may have ruptured of the biliary system, or you may have liver fractures with bile peritonitis happening. It's not very common, but it's happening sometimes. So that will be another great application of this technology to use this ICG injected in those patients. Another great technology and a great application, and I'm starting to use it, is to use ICG to identify parathyroid tissue, okay? There is a great research that was published in the Journal of Surgical Endoscopy in 2015, where they use dogs, okay? And they inject ICG intravenously, and you see the dose they use is extremely small, 20 microgram per kilogram, and they injected that IV, and then within 50 seconds, those parathyroid were lighting up pretty nicely with ICG. So you're going to tell me, yeah, well, it's easy to find a parathyroid gland. I agree. It's very easy to find them when they are attached to the thyroid tissue, because that's where they should be. But when you have ectopic parathyroid tissue, it's extremely difficult to find them because they can be very small and they can be anywhere in between the base of the tongue and the base of the heart. So looking for those into the thoracic cavity could be very, very difficult. So for me, it's a great application here that we could use this technology, injecting ICG IV in those dogs, and with thoracoscopy, we can look inside of the cranial mediastinum, see if we see any fluorescence, because those ectopic parathyroid could be very small, and it's just looking like a pin in a haystack in those cases, and could become extremely frustrating. So now, using this technology could be extremely valuable. And that's a case here that I got from the internet. It's not one of my cases, but it's an image I got from the internet from Karl Storz, and looking at an ectopic parathyroid with thoracoscopy in a human patient, okay? And it just isolated the structures very nicely there. Other applications that we should consider, and haven't used it too much yet, but it's used very, very commonly now in human. If you read all those papers or do a lit search in the literature now, it's used to evaluate tissue perfusion. Okay, you know, tissue perfusion is always something difficult to evaluate during an open surgery, for example, or even during laparoscopy. So now they are using that after doing intravenous injection at a very low dose. But now remember, this fluorescence is very short acting. I mean, when it goes IV, it goes very fast. So you need to be ready to look at it. And for example, during plastic surgeries, and they do skin flaps or muscle flaps or skin grafts, stuff like that in patients, they're going to use it to evaluate tissue perfusion of their skin grafts. So when we do skin flaps in dogs, and sometimes we do very big flaps, or we have question about the viability of a skin flap we do, it's definitely a great application to do this. It's used a lot also in human with patients with burns, to determine the depths of resection, the depths of debridement. They can use endocyanine and green, and when they start to see fluorescence, it means the tissue is perfused. So probably save that tissue, don't resect it, okay, don't debride it. It's used also in trauma patients for amputation stuff. It's used also for anastomosis, okay, when they do free skin grafts or skin grafts that are vascularized and anastomosed to blood vessel, they are going to test their anastomosis and see if it's patent by injecting fluorescence. And then if the grafts become fluorescent, their anastomosis, their vascular anastomosis is patent. But also what I'm thinking to do is use that for gastrointestinal anastomosis. I mean, you know, sometimes we have questions about viability of the GI tract when we do resection, especially when we do resections of for intestinal foreign bodies with linear foreign bodies. And sometimes we need to save some for some of the jejunum because we start to have a very big resection and we don't know the viability of the edges of the tissue. Apparently in human, it's used a lot when they do colonic resection anastomosis for colonic tumors or rectal tumors in human. They are going to use this endocyanine grain and evaluate tissue perfusion by looking at basically fluorescence or no fluorescence, basically. So it's yes or no, and that's going to tell them where to do their resections to be safe during this application. So definitely something we should be looking into for veterinary field. And also when we do gastric dilatation volvulus cases and gastrectomies to help guide us where to do our resections. Again, most of the time, those resections are not big, but we get some cases where we get to resecting 60% of it, or we have questions about viability of the fundus, viability of the cardia. That could be a great application there for us. So we need to do some investigation and research on that. Other field of application in humans is for cardiac surgeries, for example, coronary anastomosis. I mean, coronary anastomosis is a very, very common surgery in humans, okay? And always they need to make sure their anastomosis are patent, and especially now they do a lot of those surgeries on a beating heart without stopping blood flow, without stopping the heart from beating, sorry. They still have blood flow. And but those coronary anastomosis could be difficult to do, and by doing ICG, they can evaluate the flow through their coronary anastomosis, so they can evaluate the quality of their work. Same thing, neurosurgery for aneurysms, they can evaluate those aneurysms, they can visualize them, they can definitely evaluate their resections and control of those aneurysms during neurosurgery. It's not something we do in the veterinary field, but it's another great application. So like I mentioned into my introductions, it's the newer technology now. It's going to open even more this field of application, I think, okay? The Rubina technology, which is the one I'm mostly familiar with now, is when you have superimposition of the normal light, so the white light with the fluorescent images. So now the technology allows you to superimpose those two together. So now you can work with normal light, okay, like you can see in those cases, and you don't have to switch back and forth like we were doing, like I showed you, like you can see on the video in the top. Now you don't have to switch back and forth constantly. You can keep working, like you can see in the other images, you can keep working with the normal light, and you still have the benefits of having the fluorescent images in your field at the same time to guide you. So definitely that is a huge, huge benefits there. And that's basically the new development in that technology there. So you need to get a special camera again, a special light source to be able to do all this, and a special software. But that's definitely a big development that is used in human now very, very commonly, and it's coming into the veterinary world. You can see on the bottom left picture, it's a gallbladder laparoscopic cholecystectomy here. So you can see the gallbladder starts to be fluorescent. You can see the cystic duct very nicely, and you can still keep the normal light so you can visualize very nicely the rest of the tissue there. So you can see here the near infrared technology, they have very big diversity of applications, okay? And for us in the veterinary field, we are really in the learning curve, okay? Several people are working on this. I know a lot of people in Davis, at Penn, at different locations, at Guelph, are working on this, okay? So we're all trying to figure out how to use it, how much to use, the timing, So there's a lot of work to do. Obviously, you need to get the specific equipments to do this, but I think the applications are enormous. And again, in the oncology field, just for the diagnosis of sentinel lymph nodes is definitely a huge advantage here. So it's a great bridge between advanced imaging and the surgical field. It's going to help you, assist you during surgery to visualize different structures. So that's the two big things we can do with this. And definitely, I will strongly recommend you get those two books if you are really interested by this. They are not very old. They are probably 4 or 5 years ago, and they are really good. Reviewing all the different concepts and the different applications and the different utilization of this technology. And I'm sure we're going to see a lot of papers coming in the next few years in the veterinary field. I mean, that's going to be a big field of applications and development for us. So that's what I have for now. So I'm going to stop sharing my screen and see if you have any questions for me. Oops.
Yeah, Eric, we do have a couple of questions. One is there any toxicity associated with ICG?
Yeah, I mean, it's an interesting question. I mean, ICG has been used for forever. I mean, long time ago, ICG was used to evaluate liver functions and see the excretion and the clearance of it. And it's been shown in a lot of research there is extremely very low toxicity. I mean, you can never say there is no toxicity, but extremely rare to get a reaction. Some human patients have shown some anaphylactic reactions to it, but it's 1 out of thousands of cases that has been done. I've never noticed any toxicity in dogs, and the margins are really, I mean, you have to use a huge dose to induce a problem. So it's extremely safe drug. And if you stay within the dosages, we talk about 2.5 milligram for 20 or 30 kilo dogs, you can re-inject them 2 or 3 times, you won't get any toxicity. And that's a nice thing compared to methylene blue. People using methylene blue for different purposes, methylene blue has a lot of toxicity, so that's a nice benefit.
Another question is, can you use ICG to check the common bile duct patency?
Yeah, I mean, yes, that's definitely something I'm really interested in when we do, for example, cholecystectomies for gallbladder mucosal. And it's always a question we have, is the common bile duct patent, not patent? And we start not to flush those bile duct too much anymore. So yeah, that will definitely something very interesting. And it should be useful. It should be used for that purpose. Probably we need to inject them a little bit sooner, so more than 40 minutes, because if you have sludge or if you have some mucus into the bile duct, it might slow down the diffusion of it. So I will probably inject them a little bit sooner. And some protocol in humans, they inject them sometimes 2 or 3 hours before surgery and re-inject them in surgery just to increase their chance to see the common bile duct. But definitely, yes, we should be able to use it for that purpose.
And we have one last question, and that is, what do you think are the most common mistakes in using ICG?
Yeah, I've done many of those. So the number one is to get ICG into your surgical field. If you leak ICG by mistakes already when you do your injection, you let some ICG drip in the field, that's going to make everything fluorescent. So then it's really hard. When you inject it, be very slow and make sure it doesn't leak outside of the tissue, even if you inject it in the lymph nodes or if you inject it in the lung, tumor, or whatever. Be very careful with that because you're going to pay the price later. So that's the biggest concern. And then when you have ICG injected, like I showed on the lung lobectomy technique, is don't touch too many structures, because if a little bit of ICG leaked, and if you start to touch too many different structures with your instruments, you're going to put ICG everywhere. So that's definitely something I learned the hard way also. And then when you do your dissection, for example, thoracic duct, make sure you don't damage any structures there, because ICG will leak.
Okay, Eric, that is the end of the questions that we have. And I want to thank you very much for participating in endoscopy talks. I'd also like to do a special thanks to the Taiwan College of Veterinary Surgeons and Scutum, Taiwan's distributor for Karl Storz's veterinary products. And so with that, wishing you all the best of health, and thank you for tuning in.